Dear friends, I am going to talk about endoscopic management of cerebrospinal fluid rhinorrhea. Cerebrospinal fluid rhinorrhea is due to communication between intracranial subarachnoid space and sino-nasal mucosa. This is because of the injury to the arachnoid, dura mater, the bone, and the nasal mucosa. When there is a CSF rhinorrhea, there is a risk of meningitis, and this risk is more initially. It is 10% in the first 3 weeks after the trauma, and after that it is about 10% annually. The endoscopic closure has revolutionized the surgical management. About the presentation, there is a clear fluid discharge from the nose. It may be active or intermittent. This can be further diagnosed by Queckenstedt Test. That is when you put pressure on bilateral jugular vein, the rhinorrhea increases. There is something known as reservoir sign, in which the clear fluid drips when a patient is asked to bend forward. The test is ideally performed when the patient gets up and the patient is asked to place chin on the chest for at least 1 minute, and then you find that the clear fluid comes. There is a halo or double ring sign, especially in traumatic CSF leak. In that case, when there is a doubt, you ask patient to collect that fluid on the filter, and there is a central ring of blood, plus there is a peripheral ring of CSF. Handkerchief test is the fluid is blown into the handkerchief and it is dried. The handkerchief does not stiffen when there is a CSF secretion, but it stiffens due to starch in the nasal secretion. This is a double ring sign which is seen in traumatic CSF rhinorrhea because there is a blood, so blood is present centrally, and then there is a peripheral halo ring. This is the diagrammatic representation of reservoir sign. The patient is asked to place the chin on the chest for at least 1 minute, and because of the fluid already collected in the paranasal sinus, especially the sphenoid sinus, this comes out. The rhinorrhea can be unilateral, which is most common, so one should always ask whether it is from the right or left nostril, but it could be rarely contralateral leak, and these situations could be when there is a dislocation of the middle eye crista galli, or there is a meningoencephalocele which is obstructing the ipsilateral nostril. There can be bilateral leak, especially when nasal septum is deficient because of the surgery or trauma or whatever. The CSF rhinorrhea could be early, within 48 hours from the trauma. It could be delayed when it presents at least 1 week after the trauma. There can be high pressure leak, in which either there is a constant headache associated with the CSF rhinorrhea, or there may be intermittent leak with patient complaining of headache, which gets relieved after the leaking of CSF. A patient may present as a recurrent meningitis, and it is more common when there is a periorbital hematoma, which usually denotes that there is a high risk of dural tear in such case. So if you have a black eye or periorbital hematoma, then you should suspect that these patients can also develop CSF rhinorrhea later on. And there is also association of CSF rhinorrhea and obstructive sleep apnea, and such patients are associated with the raised intracranial pressure. In the workup, when a patient comes with these symptoms, we should confirm that the fluid which is coming from the nose is CSF, or it is something else, some other fluid. The other thing which we should do in the workup is to find out from where it is coming, from the nasal cavity, which part of the nasal cavity it is coming. The other thing is that we should also try to find out the mechanism of the CSF fistula. and at times it is associated with raised intracranial pressure. So rule out that. So how to find out whether the fluid which is coming out from nasal discharge is a CSF or something else? This can be done by glucose detection using glucostic test, but it lacks specificity and sensitivity. There are false positive and false negative. The false positive is because of the tears. It could be due to nasal mucus. When it is nasal mucus, then usually the glucose concentration is 10 milligram or less. This can also be false positive due to blood or airway secretion in a patient who is diabetic or having a stress hyperglycemia. The false negative could be there when there is a meningitis or intracranial infection. Although this glucose test is not specific, but it is very useful in these three circumstances. One is when the glucose concentration is usually the 30 milligram percent or more, and when there is no blood contamination, that in such cases it usually shows this fluid is CSF. And when 2/3 of the blood glucose level is present in the secretion, then also it shows that it is a CSF. But if there is no glucose at all in the fluid, then it usually shows that the fluid is not a CSF. The other test which can be performed is the chloride concentration, and it should be more than 110 milligram per liter. So if it is there, that it suggests that it is a CSF. Beta-2 transferrin is very sensitive and specific because it is not seen in the nasal secretion, but it is present in the perilymph and in the aqueous. And you require only few drops of fluid to find out this level, but it is not available everywhere. The beta trace protein is also specific for CSF, but it is also present in CSF in serum in very low concentration. How to differentiate whether the fluid which is coming out from the nose is CSF or the nasal secretion. When it is CSF, there is a history of nasal or sinus or tumor surgery or head injury. There is a few drop of fluid which comes out, and then it increases on bending forward or straining, and then the fluid cannot be sniffed back in CSF rhinorrhea. It is thin, watery, and clear, and the taste is sweet, salty, or metallic. The sugar content is usually more than 30 milligram percent, and one should compare it with the blood sugar level. It may be less when there is a meningitis. And if you perform beta-2 transferrin test, then it is always positive. Whereas if there's fluid is a nasal secretion, then there is a history of sneezing, nasal stuffiness, itching, and lacrimation. There is no effect on the quantity of fluid coming out on forward bending or straining, and the fluid can be sniffed back in the nasal cavity. It is thick, or it may be clear sometime when there's a tear. The taste is salty, and the glucose concentration is usually less than 10 milligram percent. And when you perform beta-2 transferrin test, it is negative. So when there is a clinical suspicion of CSF leak, you should try to collect the fluid and go for testing of beta-2 transferrin or beta trace protein, glucose concentration. But there is situations in intermittent leak when you are not able to collect the CSF, then you can perform either radionuclide cisternography, or you can go for imaging to find out defect, bony defect, or some meningocele About the site of leak, it can be from the anterior cranial fossa or middle cranial fossa or the posterior cranial fossa. In the anterior cranial fossa, it is from the posterior wall of the frontal sinus or through the cribriform plate or from the ethmoid roof or lateral lamina or sphenoid sinus. In the middle cranial fossa, it is the sphenoid sinus or through the middle ear through the Eustachian canal. And same causes also in the posterior cranial fossa. Regarding the etiology of CSF rhinorrhea, it could be traumatic, it could be spontaneous, it could be due to the congenital skull base defect, or this could be following tumor, erosive disease of the skull base, or inflammation. In the traumatic, it could be accidental or iatrogenic, and in the spontaneous CSF leak, it could be associated with raised ICP or without raised ICP. In the congenital skull base defect associated CSF rhinorrhea, you may have empty sella or craniopharyngeal or craniohypophacial canal, or there may be encephalocele. In the iatrogenic group, this may happen following endoscopic sinus surgery, skull base surgery, transsphenoid surgery for pituitary, or craniofacial resection. Usually the incidence of iatrogenic is about 16% of the total traumatic CSF leak. And the common causes in iatrogenic are from the lateral cribriform lamina on the right side or fovea ethmoidalis, or the sphenoid sinus or the posterior wall of the sphenoid sinus. It is important to know this anatomy of anterior cranial fossa in the region of anterior ethmoid. The leak could be from site A, that is here, that is the fovea ethmoidalis, or it could be from here, lateral lamina of the cribriform plate, or it could be from the cribriform plate itself. The spontaneous rhinorrhea could be associated with raised ICP or without raised ICP. In raised ICP, you can have multiple sites of leak, and there can be empty sella, there may be tortuous optic nerve, there may be increased subarachnoid space around the optic nerve, there may be history of intermittent headache, which is relieved by CSF leak, and there may be flattening of the posterior eyeball on imaging. So these are the features. Here you see that there is very optic sheath prominence, and there's a tortuous optic nerve. Subarachnoid space is widened and the tortuous nerve. And in this image, you see the empty sella. And in this image, you see that the posterior eyeball is flattened near the site of the optic nerve. The site of leak in the spontaneous rhinorrhea could be from the cribriform plate, most commonly, or from the sphenoid sinus. In the congenital defect, it could be associated with the raised ICP or without raised ICP. It is because of failure of closure of the anterior neuropore. There may be persistent craniopharyngeal canal, or there may be primary empty sella syndrome, which should be differentiated from secondary empty sella syndrome. In primary, there is a congenital widening of the diaphragm, and this is associated with raised ICP. In the miscellaneous cause, we can have skull-base tumors, infections, mucosal, or following radiation. Second aim in CSF rhinorrhea is to find out where is the defect, from where the CSF is coming. So it is difficult to demonstrate the exact site, especially if the leak is inactive, and there can be more than one site of leak, especially in a spontaneous rhinorrhea or even in the trauma. The localization from right to left may be difficult because of the tendency of fluid to cross the side, and especially when there's a nasal septal defect. Sometimes all the investigations may fail. There could be active leak or inactive leak. Most of the investigations are able to detect the site of leak when it is active leak. But when it is inactive leak, then it is difficult to find out by most methods. Valsalva maneuver or jugular venous compression can improve leak detection, but the role is controversial and it is not widely practiced. Regarding the primary investigations, HRCT and MR cisternography are the two most commonly performed investigations, and these are primary investigation of choice. The combined modality have a higher sensitivity and specificity, and both are complementary to each other, but getting both the investigations may not be cost effective, especially the cost is a concern. So in such cases, even CT cisternography offers the acceptable method to find out the site of leak, especially when it is an active leak. I will recommend you to go through the chapter in this neuroendoscopic surgery, a comprehensive approach of diagnosis of CSF Rhinorrhea by Dr. Nishtha. And this is the table which I have taken from her chapter, where the advantages and limitations of each modalities of detection of the site of leak is given very nicely. So high resolution CT scan has the advantage because of visualization of bone defect is better even than the MRI or any other modalities. It is readily available and cost effective, and multiplanar reformats can be done. So if you find a CSF rhinorrhea and there is a single bone defect on CT scan, this is enough. The limitations are that it detects fluid poorly and does not determine which site is leaking when you have multiple bony defect. There is a radiation exposure. It does not distinguish between a dehiscent and a thin non-dehiscent bone, and does not distinguish between secretion from CSF. The other method of investigation is MRI or MR cisternography. It is good even in the inactive leak. The sensitivity, it varies from 80 to 100%. Excellent soft tissue resolution, multiplanar reformat, differentiation from the meningocele versus encephalocele is possible. Additional finding you can see when there is associated idiopathic intracranial hypertension, especially in spontaneous CSF rhinorrhea. There is no radiation exposure, but the limitations are poor visualization of bony details. It is expensive and may be difficult to differentiate between secretion and CSF. In such situation, FLAIR image may be helpful. The other investigation is CT cisternography. It is better for depiction of the site of active leak. Differentiate contrast from the dense secretion in the blood, and high resolution image with good visualization bone can be done. It is cost effective and multiplanar reformats are possible, but it is invasive and difficult to detect low flow CSF rhinorrhea. Contrast enhanced MR cisternography. The advantages are that depiction of the meningocele is better differentiation of hyper-intense contrast from bone or secretion in T1 weighted image. The imaging can be done up to 24 hours. Therefore, it is better than the CT cisternography when there is an intermittent leak. But the limitations are, again, the invasive nature. Intrathecal injection of gadolinium is not US FDA approved. Behavioral and neurological problem may occur because of the injection of the gadolinium intrathecally. Intrathecal fluorescent injection is also quite good, and it is specific in 100% cases, but the limitation is again invasive. Intrathecal injection of fluorescein, again not US FDA approved. Seizure may occur when the high concentration is used. Radionuclide cisternography, it has the advantage that it can be done up to 48 hours or 72 hours. So delayed cisternography can be done. So therefore it is useful when there is intermittent leak. But it is invasive, does not localize the defect well, so it cannot be used as a sole diagnostic method. You can just say that there is fluid leaking out from right or left nostril. So this is useful when you are not able to confirm whether the fluid which is coming out is a CSF or not. Result can be improved by using fluorescent dye. Nasal endoscopy is also one of the diagnostic method in which you can directly visualize the leak site, especially useful when all tests to find out the site of leak fail. But it may not be effective in intermittent or when there is very minimal leak. What should we do when there is a CSF Rhinorrhea? My protocol is from simple to complex, and so go for simple test first, and then you can go for more difficult or complex test. And it varies from patient to patient. You should be able to find out whether there is active leak at the time of the investigation or there is inactive or intermittent leak. So if there is active leak, then you first go for HRCT, and it is enough when there is single bone defect. In suspicious cases, when CT does not distinguish between mucus or blood from the CSF, and when it fails to distinguish between dehiscent and a thin non-dehiscent bone. In such cases, MR cisternography is better. Or when there are multiple bone defect, in such cases you don't know from where bone defect is leaking. So in such case, if it is an active leak, then you go for CT cisternography. But there is an intermittent leak in which also there can be active leak or there can be an inactive phase. So if it is an active phase, then CT cisternography or MR cisternography are better. But if it is inactive, that means the CSF is not leaking at the time of the investigation, then MR cisternography or contrast MR cisternography is the investigation of twice. Preoperative nasal endoscopy can be used to detect the site of leak. This can be used with or without Valsalva maneuver and jugular compression, which can sometimes improve the detection rate. CT angiography is also indicated when there is a traumatic leak which involves the lateral wall of the sphenoid sinus and the patient has associated subarachnoid hemorrhage. So in such case, you should try and rule out the pseudoaneurysm of the internal carotid artery. It is essential in the investigations in the radiological diagnosis to find out whether the CSF is coming out from the medial side or the lateral side of the middle turbinate. When it is coming from the lateral side, it can be coming from fovea ethmoidalis, or it can come from the lateral lamina of the cribriform plate. One should also try to differentiate whether the leak is from the anterior or posterior ethmoid sinus. So anterior ethmoid sinus has a deep cribriform plate, while the posterior ethmoid is flat. There is cristagalli in the anterior ethmoid, whereas it is not present in the posterior ethmoid. Detection of a leak from the sphenoid sinus, it could be from the roof, lateral wall or the lateral recess, anterior wall or the posterior wall. Usually the site of defect in the lateral wall of the sphenoid sinus is much larger than the ethmoid, the leak from the anterior or posterior sphenoid location. leak from a well-pneumatized lateral recess is difficult to treat. This we can make out in this diagram, that if the leak is coming from the lateral recess, then in a normal nasal transnasal surgery, it is difficult to visualize that. And also, even if you can visualize with the angled scope, it is difficult to repair the leak coming from there. So for that, you have to have little more lateral entry. And in that case, we have to remove the maxillary sinus, medial wall, the posterior wall, the pterygopalatine fossa, the base of the pterygoid plate. And then you can get a straight trajectory and work with the 0-degree scope and the straight instrument to repair the leak. This is the anatomy of the pterygopalatine fossa. You have a vessel anteriorly and the posteriorly, the nerve and the ganglion. This is a very deep and narrow space, pterygopalatine fossa, but it is an important space because there are so many foramen, and the lesion from here can extend into the orbit, nose, the infratemporal fossa, the temporal lobe, and the oropharynx. This is the anatomy anteriorly of the sphenoid sinus. You can see that in normal cases, when you go and reach the sphenoid sinus, inferiorly we come across the palatovaginal foramen with the artery. And this is not the median now, so we can miss and interpret it as median, but it is a palatovaginal foramen. So normally in transnasal surgery, you come across this. But when you go laterally through the pterygopalatine fossa, in that case, we see the median nerve and its foramen and the foramen rotundum. And if we drill the base of the pterygoid, then we reach the lateral recess of the sphenoid sinus. Regarding the management of CSF leak, there is a conservative management. So most of the traumatic CSF rhinorrhea can be managed by conservative treatment. Observations of 2 to 4 weeks tried in after the trauma or after the surgery. But some surgeons believe that observations of 7 to 10 days is enough. So conservative treatment includes acetazolamide, laxatives, prophylactic antibiotics, head and elevations, avoidance of sneezing, and you can also use lumbar drain or can go for daily drip dry LP. There are controversies in the management of CSF leak, and these are regarding the use of acetazolamide, the use of antibiotic, use of lumbar drain, post-operative bed rest, how long one should advise rest, and type of graft, whether vascularized flap is required or a free flap or a onlay or inlay graft is sufficient, especially when you have a small leak and low flow CSF rhinorrhea. There is also controversy about the use of fluorescein to locate the site of a defect, and use of fibrin glue also is controversial. One review was conducted in which 67 studies were examined and 13 practices pertaining to CSF rhinorrhea treatment questionnaire were asked. Most people agree that there is no routine use of prophylactic antibiotic, no lumbar drainage, and various endoscopic repair material show similar success rate, especially in low flow rhinorrhea, but the larger defect may be benefited by vascularized flap, and no relevant study was there to address post-operative activity restriction, how long patients should be taking bed rest. But the most relevant points were that the teamwork of neurosurgeon and ENT surgeons with attention to specific details, that is the site of leak and the preparation of the graft bed is also very, very important. Securing the graft in place is also very important because it can also migrate, and post-operative care in CSF rhinorrhea determines the success rate after the CSF rhinorrhea surgery. Regarding use of acetazolamide, there is no need for routine use of acetazolamide when there is no raised ICP. Rather, it is harmful because it can cause metabolic and electrolyte disturbances. But it is useful when there is evidence of raised intracranial pressure. In the operative management, surgery is indicated to prevent complications, mainly infection. If conservative treatment fails, there is 3 to 10% risk of meningitis in first 3 weeks and then 10% annually. So this denotes that there is more risk in the early period after the trauma. So the indication for surgery is the traumatic leak, whether it is accidental or after the surgery. When this leak recurs or it persists even after 2 weeks of conservative trial, and all spontaneous leak should be operated because they don't stop. The leak associated with erosion or destruction of the skull base or the sinuses also require surgery. And if there is associated congenital defect in the skull base, delayed presentation after 1 week of trauma. So initially there was no leak, but delayed appearance of CSF rhinorrhea, surgery should be done. When there is intermittent leak with headache relieved by leak, usually these are the high pressure leaks, and if there is a recurrent meningitis, so you should go for surgery. The early surgery should be done in a subgroup where you think that these are unlikely to stop, even if it is a traumatic leak. So if the fracture dislocation is more than 1 centimeter, and if there is a profused continuous leak, there is an encephalocele or meningocele protruding through this skull defect, because that prevents healing. And if there is penetrating injury, there is a comminuted fracture, bone breaks into several pieces. Such case also do not stop on conservative management. And if there is enlarging pneumocephalus, more than 2 cc persistent intracranial air, despite of conservative treatment, there can be intracranial surgery, or there can be endoscopic endonasal surgeries. Success rate of intracranial versus endoscopic endonasal, the intracranial success rate is ranging from 70 to 80%, whereas endoscopic endonasal ranges between 86 to 100%. The morbidity of the intracranial approach is significantly higher. Higher incidence of wound infection, severe headache, and anosmia in the intracranial approach. Indication of intracranial approach is when there's extensive bone defect and multiple fractures involving the cranial, maxillofacial, and orbit. So in such case, when there are multiple site leaks, or when the leak site is unknown, in that case, the galeal flap can be used. This is especially useful. It can cover the whole anterocranial fossa. When there's associated intracranial hematoma, post-traumatic intracranial infection, which requires surgery. So in that case also intracranial approach can be taken. Severe or recurrent leak not amenable to endoscopic treatment also may require intracranial approach. The advantage is that you can visualize and repair the entire anterior cranial base when there's multiple and the large defects, and when there's an associated lesion which need to be addressed. The other approach could be purely endoscopic terional extradural approach, which has been suggested by Dr. Sino, and it is especially useful for frontal sinus leak, because transnasal approach may become difficult, especially if there is a well pneumatized frontal sinus and the leak is coming from the lateral sinus. This can also be done possibly with the intradural route. The endoscopic repair is possible if there's a leak in the children. The endoscopic technique has revolutionized the surgical management of CSF Rhinorrhea. There is a better success rate. It is about 90% in the first attempt and about 95 to 98% in the second attempt. There is a reduced morbidity. The sense of smell is almost always preserved. There is a short hospital stay. The craniotomy can be avoided. There is easy access, better precision, accuracy in the endoscopic technique. Regarding the indications of endoscopic approach, it is best suited when the defect is small in the sphenoid sinus, cribriform plate, anterior and the posterior ethmoid sinus. But it is difficult when the defect is large and in lateral recesses of the frontal sinus and the sphenoid sinus, especially for the beginner. In the endoscopic technique, for the CSF repair, direct paraseptal approach can be taken when the CSF leak is from the cribriform plate and the defect is medial to the middle turbinate. But you will require ethmoidectomy when the defect is there in the lateral lamina of the cribriform plate or the ethmoid roof. You may require frontal sinus opening when the leak is coming from the frontal sinus, or you may need to remove the middle or the superior turbinate in select case. The sphenoidectomy is required when the leak is coming from the sphenoid sinus, and direct exploration of the frontal sinus can be done when there is a frontal sinus leak. General anesthesia is used, the head and elevation and the patient positioning is such that both nasal cavity can be visualized by the surgeon. The endotracheal tube is fixed on the opposite side of CSF leak. The epinephrine solution soaked in cotton are used to induce vasoconstriction. Thorough inspection of the nasal cavity is done first, and the inspection should start from superior to the inferior. We use rigid endoscope. Most of the time it is the 0-degree scope, which is enough, but sometimes you can also require 30 or 45-degree endoscope. The instruments are passed generally below the endoscope, and the endoscope pushes the nose superiorly to increase the working space, as shown in this diagram. Normally 18 centimeter endoscope is enough, but at times if you require bimanual dissection, then 30 centimeter long scope may be useful, because it keeps camera, cable and telescope holder away from the nasal cavity, and it allows bimanual dissection. Telescope holder versus the assistant holding scope for you, there may be a debate, but both of them work very well for the individual circumstances and the experience. Yellow filter for endoscope can be used. The blue filter for light source for intra-operative fluorescence is useful. Leak site is identified, and at least around 5 millimeter mucosa is removed in all the directions, so that the graft can be placed on this surface and not on the mucosa. Bone is removed adequately to delineate the dural defect, and if there is any bony projection in the surrounding, or in that raw area, that should also be removed for better graft placement and graft take-up. If there is an encephalocele, it should be reduced. You can cauterize and ablate the encephalocele if it is not reducible. There can be various technique of CSF repair. It could be overlay or underlay. This is taken in the relation of the skull bone and not in relation to the dura. The overlay technique is when graft is placed extracranially. Underlay technique is when graft is placed between the dura mater and the bone. The graft may also be placed intradurally or subdurally, and one can also use combined technique in which multi-layer overlay, underlay, and even intradural graft can be placed. So this is the example. One can see that inlay or underlay graft is when this is between the bone and the dura, and the overlay is when it is outside the bone. One can also use topical fluorescein during surgery. 10% fluorescein is applied. It is applied in between middle turbinate and cribriform plate, and also anterior to the wall of the sphenoid sinus. It is better that it is first applied superiorly and then inferiorly. There is a color change of fluorescein from yellow-brown to green, and if it is seen, that means there is a CSF leak. The topical application of fluorescein is highly specific and sensitive in identifying the leaks. It is a simple and quick technique. There can be multiple defects also. So if you find one defect, you should not be satisfied. Try and find out the other leak, especially in the spontaneous rhinorrhea, which are associated with raised intracranial pressure. The repair technique could be graded repair using various things. One can use collagen sponge, fat, vascularized flap, tissue glue, CSF diversion can be used. Then we can also use support or buttress, which could be temporary, in which Marocil or Foley's catheter is used. But this could also be permanent. When the tissue is left inside, this could be bone or the cartilage. But when you use buttress, avoid using Foley's because it gives more pressure and it can cause necrosis of the flap because of the high pressure. But the Marocil is a better alternative. It causes uniform compression if applied properly. This is the example of graded repair, which has been advised by Jedor et al. For grade 0, that means when there is no leak with intact arachnoid. So if you don't find any leak or there is an intact arachnoid, in such case, in grade 0, just simple application of hemostatic sponge is enough. But when there is a grade 1 leak, that means there is a leak, but there is no obvious arachnoid defect as shown here. In that case, hemostatic sponge along with the sealant is a better option. For grade 2, with moderate leak with visible arachnoid defect, in that case, one can use fat and the sealant, and the lumbar drain can be added. When there is a grade 3 leak, that is, there is a large leak with large arachnoid or dural defect, as shown here. In this, it is advisable to use fat and also supplement with the vascularized flap and sealant, and also use rigid buttresses in the form of Marocil, or you can use cartilage or bone. along with the lumbar train. The various material which can be used in the graft are cartilage, bone, mucoperichondrium, septal mucosa, turbinate, fascia, fat, collagen, and one can use flap. So see, there are difference between flap and the graft. Graft is not vascularized. These are free tissue pieces, whereas vascularized tissues are flap. One can use composite graft. That means it involves more than one tissue. There may be mucosa along with the bone or cartilage. So it provides additional support also. The technique which can be used in CSF repair could be bath plug technique, in which the fat is introduced with secured vicryl sutures into the intradural space, and then the traction is applied so that it sticks well against the dural defect. This has been found to be safe, and this is how you should prepare the bath plug fat. The other technique is button technique, in which there is an intradural fat and there is outside the cranium fat. Intradural portion is about 25% larger than the dural defects, so that it doesn't come out. Only portion is just large enough to cover the dural defect. And both these grafts are sutured with each other. The other technique which can be used for CSF leak could be sandwich technique. As shown here, the two grafts, that is inlay and overlay grafts, are placed, and these are sutured with each other. These are especially useful when there is a large dural defect. The other graft which has been advised for, especially for the large defect, is the gasket seal technique. So in which artificial or facial lata is introduced, which is larger than the defect, and then bone or a cartilage is pushed inside, and it can be rotated so that it stays there. Then we can also use subdural grafts or intradural graft. The margins are larger than the defect to allow the adequate overlay intradurally beyond the bone and the dural margin. This is the example. One can use multi-layer closure. This is also very effective for large CSF leak, in which multiple things like fascia, fat are used. So this fascia is inlay, and then dead space is filled up by the fat, and then there is a vascularized flap over to the raw bone. One should try avoid using material in between the vascularized flap and the bone. So you can put in fat here in the dead space, but not in between the vascularized flap and the bone. Otherwise, it impairs the healing process. So multi-layer closure using graft and vascularized flap has been found to be quite effective. Then one should support these graft or the flap, otherwise it can migrate after the surgery, and this can be done by using nasal packing, using gauze piece or follies or bone or the cartilage, and also the marrow seal. So different packing material, temporary or permanent packing material can be used, with the advantage and limitations of each one of them. The obliteration technique is another which can be used, especially in the sphenoid sinus. Obliterate the space by using fat. But in such case, it is desirable to remove the mucosa. If you don't remove mucosa, there may be mucocele. We have already discussed that there are two types of material which can be used. One is the graft, which is non-vascularized, and there is a vascularized flap. So why flap as compared to graft? Because one should replace like with like. Mucosa defect should be replaced by mucosa. And there is a faster healing, and it resists radiotherapy. It does not undergo necrosis if the radiotherapy is given later on. And this is the example that when vascularized flap was not used, the CSF leak was high, and when vascularized flap was used, then it dramatically reduced. And once you refine your technique, then it can be further reduced to 5% or less. Both technique, inlay or outlay, yielded similar results. For a small defect with low flow leak, result are the same with free graft or multi-layer closure or with vascularized flap. But for high flow, multi-layer closure or pedicled vascularized flap are superior than the free flaps. Idiopathic intracranial hypertension also need to be addressed along with the CSF repair. Flap should be on the raw bone, avoid fascia or fat in between the bone and the vascularized flap. This I have already discussed. Do not try to put in any fat or any tissue between the vascularized flap and the bone, and also avoid dead space in between the graft and the bone, and also avoid sharp bony spicules. If there are bony spicules, these should be drilled or removed so that there is a good placement of the graft. And also avoid fibrin glue in between the two layers. If you are going for multi-layer closure, do not use fibrin glue between the two layers. If you want to use fibrin glue for fixing the layer, then it can be used at the margin of the graft, but not in between the two layers of multi-layer closure. The fibrin glue should be applied after all the layers have been placed. A layer of Surgicel and gel foam are placed at the margin of the graft or flap to prevent migration. Packing with Marosil, gauze piece, or the balloon impregnated with antibiotic is used to support the graft or the flap. Gel foam separates graft from the packing material, so one should put in gel foam in between the packing material and the graft, and this prevents avulsion of the graft or flap during removal of this packing material. The removal of packing material is normally done after 3 to 5 days, but it can be kept for 10 to 12 days when the defect is large and there is a high flow CSF leak. The bed rest is advised for 3 to 5 days with the head elevation. This is controversial. Some people advise early mobilization. A role of navigation is there for correct localization of CSF leak in difficult cases. Perioperative prophylactic antibiotic is given. Again, this is also controversial. Avoid nose blowing, sneezing, or Valsalva maneuver after the surgery. And patient should be told that in case there is a sneezing, then the patient should open mouth so that the pressure does not build up. The stool softener should be used to avoid straining. Direct suturing of the dura can be done. This is an alternative technique, but it requires quite a bit of expertise. One can directly suture the dura, or one can use fascia if the defect is large. So this avoids fat or graft for repair of CSF. This is a short video of a leak from cribriform plate. This was a spontaneous leak. One can see that there's a leak on the right side. In CT also there is a dehiscent bone on the cribriform. So a small vascularized flap was elevated, and then we try to localize from where the leak is coming. So now we can see that there is a meningocele small meningocele, and the mucosa surrounding this defect was denoted and removed, so that at least all around at least 5 mm of mucosa is removed for better placement of the graft and good healing. All the dural defect should be very well visualized. It is seen here. And then we use fat secured by the vicryl. So it was placed intradurally. And then one fat was used only, and these two were tied with each other. So this is known as button technique. So it prevents migration, and after that, the vascularized flap is also positioned against. It was also used just to have additional support, and then fibrin glue was used so that there is no migration of the graft. And then a little bit of Abgel was used to support. The another variety of leak is the frontal CSF Rhinorrhea. Frontal CSF Rhinorrhea is difficult, especially when there is a lateral extension of well-pneumatized frontal sinus. When you go from ipsilateral side, it is difficult to reach at this lateral recess. So go from the contralateral side and also use anterior superior septostomy. And this is called as modified Lothrop procedure. This is the example of direct repair of the frontal sinus, and this is especially useful when there is excessive pneumatization and the leak is from the lateral side. Here the incision is given directly onto the frontal sinus, just on the eyebrow, and the outer table is removed, and the endoscope is used to visualize the defect in the posterior wall of the frontal sinus, and the repair is done. Regarding the results of endoscopic technique, there is over 90% success rate, and the success in the second attempt reaches to almost 98 to 99%. Recurrence may occur very late, as long as 80 months. It has been reported by one of the author. So therefore, there is a long follow-up is required before you call the procedure as successful, especially when there is a spontaneous rhinorrhea, because the recurrence may occur very late. The complications could be meningitis, chronic headache, pneumocephalus, intracranial hematoma, frontal lobe abscess, recurrences, flap necrosis, sudden nose deformity, mucosal, and there may be anosmia, there may be seizures, memory deficiencies, and behavioral changes. The flap can also get avulsed, and also try and prevent flap necrosis by avoiding high pressure. There may be saddle nose deformity. Recurrences may occur in CSF rhinorrhea after the repair, especially in spontaneous rhinorrhea, and when there is an elevated body mass index of more than 30. It may occur when there is a lateral recess CSF leak in sphenoid sinus, which is well pneumatized. The extensive skull-based defects are there. Middle-aged obese female, empty sella, when there's a raised ICP. So this also must be addressed along with the repair of the defect. Multiple sites of leak, diabetes mellitus, and the frontal sinus leak coming from the lateral side and in a well-pneumatized frontal sinus. So idiopathic intracranial hypertension can be associated with CSF leak. CSF pressure should be routinely measured post-operatively through the lumbar puncture, especially in cases with the spontaneous rhinorrhea. So some authors have advised continuous perioperative ICP monitoring to diagnose if there is associated raised ICP. And if it is there, then there is a need to lower this ICP. Otherwise, in a long term, there will be a recurrence. The special problem in spontaneous rhinorrheas are that about 50% of them are associated with the occult elevated ICP. There is no frank elevated ICP because the raised ICP is relieved by intermittent CSF leak. There may be multiple skull-based defect. So diagnosing one during surgery or before surgery is not enough. There could be more than one. The high rate of meningoencephalocele formations are there in spontaneous rhinorrhea that should also be reduced or ablated. CSF pressure monitoring should be done post-operatively. We have discussed this already. There can be two types of leak. One is the high flow leak and another is low flow leak. In high flow leak, it is better to use vascularized pedicle flap, and the one can also use lumbar drain. If it is persistent, then one can use either VP shunt or LP shunt. And use of acetazolamide is also indicated to lower the ICP. If it is low flow leak, then you can use vascularized pedicle flap and also the graft. The indication of lumbar drain are in recurrent cases when there is a persistent leak, there is associated hydrocephalus, elevated ICP, two cisterns or the third ventricle has been opened. There is large skull-based defect with meningocele. The patient with body mass index of greater than 30 and radiographic evidence of empty cell syndrome. Lumbar drain can be kept for 3 to 5 days, and after that you tap 24 to 48 hours after the removal of the lumbar drain and measure the pressure. If the pressure continue to high, then we need to go for shunt. Regarding the lumbar drain, it could be two types. It could be continuous or it could be intermittent serial lumbar puncture. Both of them have some limitations and advantage. The limitation of continuous drainage is that there can be over drainage syndrome and there can be infection when it is kept for a long time. Limitation of the serial lumbar puncture is that it is uncomfortable, and in between there may be raised pressure. So intermittent drainage, keeping a indwelling catheter inside the thecal sac is a middle path, which I think is appropriate. Approximately 5 to 10 ml of CSF per hour can be removed, or the CSF can be removed twice in a day via this catheter, approximately 30 to 40 ml over 15 to 20 minutes time. So intermittent lumbar drain is a viable option with twice daily removal of CSF, and it avoids the disadvantage of continuous drainage. We have two training program. One is 11-month university certified neuroendoscopy course and 1 week fellowship program, which we conduct twice in a year. So to summarize, identify that the fluid which is coming from the nose is CSF and not any other secretions like nasal secretion. In spontaneous rhinorrhea, about 50% of these cases have raised ICP. So identify signs of raised pressure like intermittent leak associated with headache and which is relieved when there is a CSF leak. There may be more than one site of the CSF leak. HRCT is enough when you find a single bone defect, but if there is a difficulty in finding out whether it is mucus or blood or CSF on CT scan, or it is difficult to find out from dehiscent bone to thin non-dehiscent bone, or if there are multiple fractures, or also in inactive leak. So in such situation, it is better to go for MR cisternography. CT cisternography also has a place in active leak, and especially when there are multiple defects on CT scan. Topical fluorescence for intraoperative diagnosis of CSF leak can be used. It is quite effective. Flap should be on the raw bone. Avoid fascia or fat in between bone and flap. No bony spicule, no dead space, and remove at least 5 mm of mucosa around the bony defect. Recurrence may happen even very late, especially in spontaneous rhinorrhea. It is difficult to repair the lateral recess CSF leak from the sphenoid sinus and from the frontal sinus. There are some indications of a lumbar drain, and intracranial approach can be used in select case when there is extensive bone defect and there are multiple fractures, and if there is associated intracranial lesions, and also when it is difficult to find out from where it is leaking. So a large flap can be laid over the anterior cranial fossa. You can refer to these articles. Thank you very much. Thanks.